Yes. So, good evening, everyone. So, we've started this webisode or online, rather, education program on GI HPB oncology, and we are almost into our second year, and this is 39th webisode. So, we've covered most of the topics in GI HPB oncology, and now we are doing colon cancer. So, last webisode we covered the introduction and basic approach about colon cancer, and in this we'll talk mainly about operative steps, techniques, tips, and approach. So we have a very esteemed faculty here. We have Dr. Deepak Govil, who is GI surgeon at Apollo Hospitals in New Delhi, and is running a GI HPB oncology program. We have Dr. Avanish Saklani. He is GI HPB mainly colorectal oncosurgeon at TMH Mumbai, and Dr. Sandeep Nayak, who is at Fortis Bangalore. So none of them needs an introduction. And to save time, we'll start with introduction and approach, and then followed by right and left-sided colonic resections. So, Dr. Govil, please.
I'll just share my screen. Is my screen visible?
Yep.
Yeah, I can start.
Yes, absolutely.
Yeah, good evening, everybody. I think, Nikhil, it's a very good program and good endeavor that you've started last year, and I think should be helping a lot of residents and a lot of surgeons. I'll be speaking on the surgical anatomy, principles, and overview of colonic resections today. And I plan to cover this topic under the basic anatomy, certain surgical tips related to the anatomy, current concepts, then few specific issues I would dwell on, and conclusions. This, I think, as you all know, all the surgeons, I suppose, who are viewing this, the colon, the parts of the colon, the cecum, the right flexure, left flexure, and the rectum, sigmoid, and the rectum. This is just the basic parameters, the diameters. I think the main thing is the widest likely site for perforation is the cecum here, as you can see, and the narrowest and likely site of obstruction is the sigmoid and the rectosigmoid junction. But I think overall, this just describes transfer. The length is almost 1.5 meters for the large intestine. I would start right from the embryology for the colon and the blood supply, because today it has become more and more important with the planes for surgical procedure becoming more and more clear, more and more magnified with the use of minimal access. I think we need to know the basic embryology, and the basic embryology, the blood supply to the colon and the rectum is partly from the midgut area and partly and from the hindgut area. So mainly superior mesenteric artery partly and inferior mesenteric artery. And these are the areas like the ascending colon on the right side is fixed and the descending colon is fixed, but we have a mobile transverse colon with a long mobile mesentery and a sigmoid colon which also has a mesentery and is quite volvulus is common because it has mesentery, but the other parts are relatively fixed. Coming to the blood supply, as I told you, I think most of you know that this is the superior mesenteric artery, and this goes on and forms the ileocholic vessel, then the right cholic vessel, the middle cholic vessel, the right and the left branch, the left cholic vessel, and the sigmoid arteries, and then the IMA goes as a superior rectal vessel. The lymph nodes for the colonic cancer mainly are along the feeding vessels, and they start right from the intramural part to the extramural part, and then epicolic, paracolic, and then go on to the root of these vessels. So basically, the principles would vary according to the lymph nodes and the areas which need to be resected. So coming to the areas variation on the variation on the right side, like this is the cecum and the ascending colon, where the ileocolic artery is fairly clear and fairly regular, and the right colic artery is only present in around 10 to 40% of patients, and it may be sometimes variable, maybe starting from arising from here or maybe absent completely, or maybe arising from a part of the middle colic vessel also. So these are the variations which can occur with the right colic artery, and it may be absent in almost more than 50% of patients. Coming to the middle colic artery, that also has a lot of variations. There can be a common trunk with the branches on the right side and the left side. There can be common trunk which can divide and be more on the mid-transverse area. Then there can be another branch going towards the splenic flexure area, or even sometimes even middle colic may be absent and may be supplied by these, but this is not very frequent. This, I think, would be more important for the rectal procedure, which I would not like to cover at this stage, whether you ligate the IMA at which level. I think we would go to this. The IMA gives rise to these branches, the left colic branches, and the sigmoid arteries on the left side arise separately. This is the majority type 1, almost 58%. Then in some patients, around 27%, there's a common trunk which divides into the left colic and the sigmoid vessels, and they can be right from the beginning. They can be two vessels arising from the same origin in the left colic and the sigmoid vessels. So all these things, I think we should be aware while we are planning for a surgical resection, so that all these variations are commonly seen. Then there are collaterals which develop between the SMA and RNA and IMA, and the collaterals can be in the form of a marginal artery of Drummond, as you can see, which can give rise to this vessel, and going towards the forms collaterals towards the inferior mesenteric vessel. Then this is arc of Rayolin, which is also a common site from where a superior mesenteric artery can have a collateral circulation with a inferior mesenteric artery. And then also there's a meandering artery of Moskowitz, which sometimes has a relation with the right part of the middle colic and goes into the left colic vessels. This can sometimes be seen in patients, but not very frequently. And all these vessels help if there's any IMA after the IMA ligation, or any increasing the vascularity if one of them is partially blocked. As I think these are the areas which help in the collateral circulation. The distal part of the rectum derives a supply from the internal iliac artery via the pudendal artery, which gives rise to inferior and middle rectal arteries, whereas the superior rectal comes from the IMA. Coming to the kinds of resections, I think mainly since we are talking about the colonic resections, we'll be talking about the right hemicolectomy, extended right hemicolectomy, the left hemicolectomy, sigmoid colectomy, and sometimes subtotal or a total abdominal colectomy. If it also depends on the site of the tumor. If there's a tumor in this part, usually you would go and resect and do a right hemicolectomy. If it is more to the hepatic flexure, then you would do an extended right hemicolectomy. If it is in the transverse colon in the right side, usually you may consider going ahead with an extended right hemicolectomy instead of this. If it is on the splenic flexure side, again, there are variations. If it is an advanced lesion, you may consider going ahead with a extended resection and then a left hemicolectomy. And for a lower part, you may consider an anterior section. Overall, the bowel resection, obviously, the approaches are different. You can do an open approach or a laparoscopic approach or a robotic approach, but the basic surgical principles remain the same. And obviously, the key to adequate resection is the blood supply to the colon. And for a benign disease, your resection may not be as extensive. You can do a limited hemicolectomy right side in tubercular disease or any other benign cause frequently. For a malignancy, it should aim to resect the named colonic vessels supplying the cancer bearing portion of the colon as close to their origin as possible. And regarding the lymph nodes, usually they said that if the minimum number of lymph nodes which we should be harvesting during a colonic resection should be more than 12 to say that it is an adequate resection. There has been a significant conceptual change even in the colonic resections after the TME has become so popular and the outcomes of TME. From TME, we've come to CME. Like you can see, there's Hield and Quirk was the pathologist and the surgeon, and here is Hohenberger and Bill Hield together, who popularized the CME technique for colonic resections with complete mesocolic excision. TME, CME with central vascular ligation has been shown to show better survival rates as compared to excision of specimens with effective mesocolons. Like if you do a TME, you grade the specimen of TME by a pathologist, grades the specimen, and then says that it's a good resection, which not only includes the number of lymph nodes, but the kind of resection, or if there are lacerations or defect in the mesocolon, then you say that it's not a good specimen. There's a grading, Quirk's grading for a TME specimen. Similarly, these specimens also can be graded. If there is a defective mesocolon, the chances of survival do differ in patients who have a good, proper mesocolic excision. This obviously has come in a big way, and you dissect right at the root of the mesentery and take all the vessels and at this level. And usually a top-down approach is preferred, as you'll see shortly. And this is what you should be looking at, like after the resection, the specimen, the abdomen should be clearly showing these structures, which are, and since you go in the basic embryological planes, the vascularity and the bleeding obviously is limited in these resections. But obviously they need a lot of expertise and practice for excision. This is similar to Japanese, say it has a D1 or D2 or D3 resections. In fact, the D3 resections are the ones which are similar to the CME and CVL procedure, where you resect right at the root of the vessel. For a central vascular ligation, depending on the site of the location, like if there's a cecal or ascending colon resection, then you ligate the ileocolic vessel and the right branches of middle colic, whereas the right side, again, the ileocolic and middle colic, and the middle and left transverse colon and upper descending colon, you divide the middle colic, ascending branch of the left colic, and if there's a any site of descending colon to the rectosigmoid, then mainly the inferior mesenteric vessels. For a transverse colon lesions, the lymph nodes which need to be excised are significantly more, because in these, if you go to the roots of these vessels, you tend to dissect the subpyloric lymph nodes and the mesocolic lymph nodes here near the pancreas and peripancreatic area also. This is again the right gastroepiploic lymph node group, the left epiploic lymph node group, and the pancreatic head lymph node. This is a concept, I think, which if you do a CME, you should be clear about. There's a gastrocolic trunk of Handley and its variants, and a lot of Japanese and others feel that probably the lymph nodes are more close to these vessels, the venous area, and the root of these gastrocolic trunk needs to be cleared if you want to do a good resection, and especially in the right hemicolectomy for a lesion in the hepatic flexure or in that area close to the right side. You need to do a good resection, and you should be aware about the anatomy preoperatively, preferably, because these are the areas which are very prone to bleeding while you're operating. So these are the areas, and you go through. This is the right gastrop and the Henel's trunk. This forms the right gastroepiploic vein, the anterior, superior, or inferior pancreatodudinal vein, and then the right colic vein or a superior right colic vein. So there can be a lot of variations. This is one of the commoner ones, and there can be a separate right colic vein and a superior right colic vein. And these are the variations which can occur. In majority of the times, you follow from the right gastroepiploic vein and you take a top-down surgical approach while you're doing these procedures so that you can reach to this gastrocolic trunk and clear lymph nodes at that level. Again, this is the portal vein, and this is the area where you need to clear for right hemicolectomy. These are the, if you right from the ileocolic vessels to the Henel's trunk area, these need to be cleared. These are the jejunal veins. These all need to be cleared if you want to do a CME resection. Overall, the basics after the CME technique, this favors a 10 centimeter rule for proximal or distal margins, at least, because majority of the times our resections follow the guidelines of the blood vascular supply. But in addition to that, the minimum of 10 centimeter margins is preferred on both proximal and distal margins for a colonic resection. And sufficient proximal and distal margins are needed to remove the mesocolon containing the lymph nodes and improve the oncological outcomes. Overall, the length of bowel resected and the amount of mesocolon containing lymph nodes are closely interrelated. So it is difficult to assess the direct impact of bowel length on outcomes, but basically these are the rules which have been laid down preferably. Then certain issues which I would like to just add a little, whether you should be doing an intracorporeal anastomosis or an extracorporeal anastomosis or a stapled or a hand-sewn anastomosis. In fact, these will be mainly covered by the other speakers who will be speaking on the surgical procedure. But usually an extracorporeal anastomosis, you do the anastomosis as you do in open, and the comfort level of the surgeon is more, especially in the initial phase, you prefer to do a extracorporeal anastomosis. And only if in an expert hand you plan to do an intracorporeal anastomosis and then a mini laparotomy to extract the specimen. But majority of the people still prefer an extracorporeal, because even in this you have to give a small incision. Overall results and comparison have shown a little advantage of doing an intracorporeal anastomosis in overall outcomes. This can be done again by a stapled or a sutured technique. Stapled obviously is a relatively easier technique. Suture definitely requires a much higher learning curve and much more expertise. So overall, as I told you, intracorporeal anastomosis, if feasible and expertise is available, may be preferred. With a robotic, that is one thing which probably has been an advantage. Then again, hand-sewn versus stapled. This has been going on for years, the comparison of hand-sewn versus stapled anastomosis, and majority of the studies have not shown significant difference, but of late, a few studies have shown some advantage in the stapled anastomosis, but still, I think it's a matter of a personal preference. Basic tips, I think, for any anastomosis, I think tension, any rotation of mesentery, I think this is an important part, especially in colonic anastomosis and the right colonic anastomosis, especially ileocolic anastomosis. You should be very clear, because rotation of mesentery is a possibility in such situations. Vascularity obviously has to be good if you've done an anastomosis. And also in majority of these colonic anastomosis, you don't need a stoma, but rarely, maybe 5 to 10% of patients, if you're not very happy with your anastomosis, or if for some reason the bowel wall is not very good and you do an anastomosis, then you should not hesitate in defunctioning and covering that with an ileostomy. We, in fact, as I told you, for a right colonic anastomosis, have now stuck on this technique. We tried initially if we do a extracorporeal anastomosis. Initially, we were also doing a double barrel anastomosis as this. But with this, the twisting, we faced a lot of issues with twisting, with these staples getting adherent to the bowel, causing adhesive obstruction. A lot of these issues came. So now we've shifted to isoperistaltic anastomosis. We staple both the ends and do a hand-sewn anastomosis on the side to side. And we are quite happy with this anastomosis because this is more of a natural flow for a right hemicolectomy anastomosis. So overall, I would say for the residents that you should pick up threads of techniques from all your teachers, masters, and colleagues, and make your own technique which you feel is the best and you're confident about, and develop your own technique for any surgical procedure. So to conclude, I would say that anatomy of the colonic vascularity is important, as outcomes are dependent on the anatomical clearances. Margin of 10 centimeter on either side is sufficient. Minimum 12 lymph nodes should be harvested. CME and CVL is should be done if expertise is available. And these all things have become more and more important as minimal access surgery is getting more and more popular in the form of laparoscopic or a robotic procedure. Thank you.
Thank you, Dr. Govil. Thank you for a comprehensive presentation, and it sums up the brief approach which a student or even a practicing surgeon should take to colon cancers. And we have some of the questions in the chat box, so I'll ask you those questions, and let me open the box. So somebody, Siddhamed, has asked embryonal variations of vein supply and its implication in CME. So I guess you've covered that, but can we talk about any other venous variation which has any implication on the surgical aspect?
I think mainly these are the areas which need to be covered, and one should be aware of this Hennell's loop and gastrocolic trunk. All others, majority of them I have covered.
Yeah. And he also wanted to know about points in the colon where there is lack of vascularization, like Sudeck point. So what is the implication?
I think those are the points, because basic anatomical points, as the splenic flexure is the area where the vessels, SMA and the IMA blood supply meet, and that is the watershed area for a colonic anastomosis. So if you have to do a anastomosis, try to avoid that area, and preferably include a splenic flexure and do an anastomosis a little low down sometimes.
So I mean, if you have to do extended right hemicolectomy, so would you always make it a point to include the splenic flexure in the specimen, or you're okay with
always,
leaving splenic?
No, yeah, not always, definitely.
So, I mean, these anatomical variations or this watershed points which have been described, I haven't actually found them practically very, very useful. What's your opinion there?
Yeah, I agree. I think just at the time of the surgery, you really make these decisions, and but preferably for a transverse colonic growth, I would always, even if it is on the right side, I would go ahead and do a splenic flexion mobilization into it a little lower in the descending colon. So all these decisions, I agree, Nikhil, that obviously theory is theory and practical. At the time of surgery, what you see, how vascular the anastomosis is and the vascularity of the vessels. But yes, the lymph node dissections and going to the roots is important. And with laparoscopy and robotics, this has become a little better, I would say.
One more question which I had in my mind was you said intracorporeal could be either stapled or hand sewn. Like what generally most of us or I do is that we fire one stapler and then sew the cut end, the defect. I think that's a good combination of both. And can you just elaborate a bit when? Majority. Sorry.
Majority would do that only, and only with the robotics, people are now trying a complete hand sewn one. But majority would do a stapler with a closure of the defect with a suturing problem.
Yes. And maybe you can elaborate a bit. When would you defunction anastomosis in colonic resections?
In colonic resections, I would have a little low threshold in left-sided lower colonic resections for a stoma doing an ileostomy if there is a doubtful viability or vascularity. In case there is some doubt, then I would prefer to revise and do an anastomosis. But if the wall overall is edematous, it is not very good, then preferably I would do a diverting stoma. And that is why, in fact, but pre-operatively counseling these patients, you should just give yourself a chance of 5 to 10% and always tell a patient that there may be a possibility. Although majority of the times you will come out without stoma in these patients.
Yes, exactly. Do you bury the cut ends? Do you bury the cut ends?
In fact, I was not doing it, frankly. But I've started, we had 2-3 patients where we sequentially had problems. And this is the technique we started. And now, touch wood, with all these, we are going okay. So I have started. Still, I don't do this, but I think double barrel anastomosis, I'm not very happy with. Even in a small ball stapler anastomosis, I'm not very happy with the double barrel anastomosis. I prefer to bury the ends in case we do it.
Margin would you be happier with less than 10 centimeter or you want 10 centimeter?
Margin C accepted is 10 centimeter, and majority of the times you are able to get it only in a distal tumor and a very rectosigmoid tumor. In those cases, it may not be sometimes possible, but majority of the times you would be able to get a 10 centimeter.
Yes, mostly.
Yeah.
So we have a question from Dr. Deepak, and he has asked, in descending colon malignancy, 10 centimeter distal to splenic fracture, what should we do? I guess we can ask this question in the left-sided colonic resections. And Dr. Siddharth has asked one more question. When we do a lateral to lateral anastomosis for right hemicolectomy, how many staplers do we use? He says, I use a single 80 mm.
No, for lateral to lateral means side to side.
Maybe that's what he means, yeah.
Side to side, obviously, for the transection, you can use one, and then for the anastomosis, you can use one. That should be fine. Yes. But if you're transecting with a stapler, then usually 2 staplers should be fine. Sometimes 3 staplers may be required.
I get it. So my colleagues, Dr. Manish and Dr. Shefali are also here. Manish, do you have any questions? Any comments? Shefali?
So I think it's being a surgical topic, even if I ask a question that is already answered. So no questions from my side.
Nani, you're most welcome.
Dr. Shefali is medical oncologist. Sorry, I didn't introduce her.
No, sir, I know sir for last so many years.
Oh, yeah, Apollo. Yeah, so sorry, yeah, I couldn't connect the dots.
Yeah.
Manish?
Yeah, it's excellent talk. I am driving. I am Baptist again. Rain actually. Yeah, I was listening, but it is an excellent talk. So just I want to ask, sir, like the variations, vascular variations he has told. So actually speaking, are these minor vascular variations do carry any meaning when, because we don't see them on CT scans most of the time preoperatively unless it is a very major vascular variation. So
I
how do you
think,
go, like,
yeah, see, I think routinely I agree we don't go after these vascular variations because they really do not. I think the only role of these assessing these vascular variations is when you're making a colonic conduit for any esophagus. Otherwise, apart from that, these vascular variations for a resection majority of the times are usually not very helpful. But if you have an idea, it may be better, especially for a CME, because you tend to go to the roots of the vessels, and if you are a little better, you have little better knowledge about the anatomy, it may be worthwhile for a CME.
So I had one question. I mean, this is not only now, I had always in mind. So we call CME and we call D3. Uh, I mean, is there any other way of doing colon cancer surgery? So maybe you can guide us. Older times, were people doing it differently? Because since we have learned that's the way thing has been done.
I think
Maybe
probably it's a little standardizing the technique a little more clearly. Like we were probably not going to the roots and central vascular ligation and all. We were just clearing the lymph nodes maybe earlier, but yes, I agree that majority of the times we have been performing these procedures. But I think with the minimal access thing, I think it has become more and more, the dissection has become more and more meticulous. Probably that is the reason.
yes. Thank you, Dr. Govil. So with
Yeah,
this,
thank you.
thank you. And Dr. Saklani, I think we should invite you now to deliver your talk. And if you have any comments on the previous conversation we had, you can start with that also. And we would be happy to hear
Hi,
your comments.
hi, Nikhil, and hi, Dr. Govil. Great to hear your talk. I think it was quite complete actually. But I think I have very little to do for my next talk, which is just talking about left colectomy, topic which I don't do quite often, but anyway, that should be okay. So my topic today is left-sided resections. So I think Dr. Govil has described quite a thing about the anatomy of the left colon. So I don't need to do it again about the vascular supply. But what we need to be careful about is the marginal artery. So you have the marginal artery of Drummond that he spoke about. Then you have the second link, which is, so this is the marginal artery of Drummond, which may sometimes be absent there. And then you have the Riolan's arch there. So you have to make sure when you're mobilizing this colon, this arch doesn't get damaged. So sometimes when you mobilize it after an anti-resection and left colon, and then you make a dyschemia of the colon. This can happen in very obese people when there is bleeding from a mesentery. And then there is another artery called the mentoring artery, which connects the superior middle colic artery and the left colic artery sort of thing. This mentoring artery you see when you do high ligation of the inferior mesenteric vein there. So if after ligating the inferior mesenteric vein, you see a main artery there, that's the mentoring artery. And sometimes that can be the main artery supplying the left colon. So if you ligate this and this, and you may end up ischemia of the colon. So I think every year we will have about 2 colons after low anti-resection, which may become ischemic because of this mentoring artery. So we are very careful about that. So we all know about the facial planes that we spoke about. We always try to go in the facial planes, and we do our anatomy based on that. We very rarely follow structures. For rectal cancers, we follow the TME plane. The most important thing is about location of the tumor. So what should you do? So left colon is very uncertain. So if you have a tumor in the descending colon, if you have a tumor in the sigmoid colon, then it's very straightforward. You do a sigmoid colectomy, you transect the rectum somewhere around So suppose if you have a tumor across at this point, so you would probably take the left branch of the middle colic and then take the left colic here and do a segmental colectomy. Some people, if the tumor is around here, you will take the left colic and the sigmoid and may do a sort of formal left hemicolectomy. But if the tumor is the sigmoid, most people may even take the IMA at the root and join it at the level of promontory. So most important, if you have the left colon lesion, you should have a plan of your operation itself. So you realize that this is a splenic fracture tumor, so you have to decide whether you want to do an extended right hemicolectomy or you want to do a segmental hemicolectomy. And based on that, those blood vessels have to be taken. What you don't want to do is, suppose if you have a tumor around there, and you take the inferior mesenteric artery at the root, and after taking 10 centimeter margin, your colon may not come down for an anastomosis. And then you are in a bit of a trouble because then you have to mobilize the whole of the colon. The other thing what can happen in left colonic, when you join this transverse colon to the sigmoid here, there's a big gap because there's a tension there, and the small bowel can herniate in this gap. So internal herniation after left hemicolectomy is very common. So you have to be very careful while doing it to make sure the transverse colon is superior to the peritoneum there. The other thing, suppose if you've taken the left colic here and you don't have enough length to join it, you may have to mobilize the whole of the right colon, okay, and you may have to do a transmesenteric passage to join it. The length is short. The other thing, if this colon still doesn't come down there, sometimes you may have to ligate the middle colic and put the right colon reversed, okay, which is a Delaware's procedure. You will get these problems on and off there. And so you should know all the options which are available. So, okay, so for splenic flexure tumors, what should you do? Left hemicolectomy, subtotal or segmental? So a lot of things. The National American Entrustive Database, they try to compare. There are no prospective trials. There was a very small trial from France which found there was no difference, and segmental resection of left colon was equivalent to proper left hemicolectomy or a subtotal colectomy. The largest multicentric propensity is from the Grecar group with 313 patients. They compared all the three and they found no difference in survival. There are many other retrospective studies, they found no difference in survival. I'll just show a small video of a left hemicolectomy sort of thing. So this is a 27-year-old male with no comorbidities, and the lesion is 32 centimeters from the anal bulge. CT is non-metastatic. You can see the lesion there. Sometimes they are very small and you may have to tackle them before. So we always do surgery like this, but now it's labeled as complete resection. So we normally have 5 ports. Both the lower ports are 12 mm. So first you do an examination of the colon and you localize the lesion. So for this one, we know the lesion is the descending colon. So we have decided to take the left colic and preserve the superior rectum. Then you get the bowel into position. Our main idea for left colon or all left-sided resection is to first go along the inferior mesenteric vein and find the facial plane, and then you enter the lesser sac from the pancreas. Entering the lesser sac is not always very easy. You can take the inferior mesenteric vein at the root. There is a lot of variation in inferior mesenteric vein. Recently, there is an article on colorectal disease on all the variation. Here you can see this is the inferior mesenteric artery which is going there, and that's the left colic. So our plan is to delineate the inferior mesenteric artery, define the origin of left colic artery. So just like you do for an anterior resection, you lift the rectum up completely. You define the inferior mesenteric artery by cutting from the groove and along the IMA. This cut is different. Some people make a cut in the promontory. I normally lift it up and tend from the groove in the pelvis. And once you cut the peritoneum, you start seeing the artery. Because you already dissected the vein you were plane, you dissect along the inferior mesenteric artery. You come to the root of the inferior mesenteric artery. Once you do that, you can drop the nerves down and you can see the origin of the left colic artery. So you made the entire thing below. You can see the IMA going there. The mouse will be there as well, so it's safeguard them. So if you're in the right facial plane, so now when you lift the vein up, the left collic will actually follow the vein as well. So what you do, you take the fiber fatty tissue along the inferior mesenteric artery and along the left collic. So you follow the vein. This is the inferior mesenteric artery. So here we know you also have to make sure the sigmoid is completely free. So sometimes you may have to enter the pelvis to make sure the sigmoid is completely mobilized. Because if you cut the transverse colon very high, then your sigmoid will come up for a left hemicolectomy. If you've done good resection, then obviously medial to lateral resection, then you should be able to enter the blood. Because I normally use most of the time monopolar. I think this is one of my fellows, I think of the G2. So you mobilize the whole colon there. So here you're mobilizing the splenic flexure. While mobilizing the splenic flexure, you detach the momentum slowly from there. When the colon is mobilized, you see the junction of left colic and IMA, and so you're ligating at the root, there's central ligation here. It's like in right colon, you're thinking about the superior mesenteric vein all the time. On the left side, you never actually think about the vein, you only look at the artery, that is central ligation. But no one ever says that you ligate the inferior mesenteric vein, because the nodes along the inferior mesenteric vein have never been found to be significant. So once you do that, then take the left colic, then you take all the branches along the superior rectal artery to get enough distal margin of about 10 centimeters or so. And then you can transact the distal margin. So here, for the distal branches, we first transected the colon and took the distal branches later on. So it becomes easier because all your job is to just protect the superior rectal artery. Then you can see the length of the colon which is there, looking for it, and you can take 10 centimeter proximal margin. You can do an intracarpal anastomosis. So here you have enough length of the colon, so you do an end-to-end anastomosis. You make sure that there is no tension there. You also have to make sure there is no small bowel under the root of the mesentery, because otherwise you can add internal herniation there. It was T3 and 0, and 0 out of 33 nodes, you look for a mid-size status there. On the other hand, if you were doing an anti-resection, or whatever, or upper proper sigmoid resection, then the outcomes will be slightly different. So again, we follow the same plan. We dissect along the inferior mesenteric artery. You can see the white line there. We dissect along the inferior mesenteric artery. You can see with the monopolar itself, you have good planes. You do a seagull sign, then you lift up the left colic artery and ligate the IMA and the root. This is the array procedure. So once you do this enough, then you can do a lateral cut. While mobilizing the splenic structure, the person and the assistant is pulling the colon down from the right side. The other person holds the momentum, and then we detach the momentum from the thing. For the pelvic dissection, we put a tape around the rectum and hold the TME plane. Once you do a posterior dissection, then you can do the anterior cut there. Because I know this is a sigmoid thing, but even for sigmoid, sometimes you may have to go at least 5 centimeter distal margin. And while you may think you should always do more than what is required, because it's not uncommon. Even for sigmoid colectomy, have a 2-3 centimeter margin, and you might be underestimated. You may sometimes take the middle colic. You need enough length. I think the middle rectal itself will supply 10 centimeter after peritoneal reflection there. Here, I think we are doing PME, so we're going down to the pelvic floor. So I think this is the resection. We're doing only left colon resection, but this is just to make sure you have enough mobility. Sometimes even if you have to left hemicolectomy, you have to make sure the sigmoid is mobilized and you have to go completely down, but not take the vessels. So the main things for a left colectomy, you have to decide what you're going to do. You're going to preserve the superior rectal artery or not, what is the margin you're going to take. Unless you plan it before, sometimes you can be stuck in a really long operation, or you may have short length of bowel. If you have short length of the bowel, then you may sometimes have to mobilize the right colon as well. You may have to do transmesenteric passage, and sometimes you may have to reverse right colon. Okay, so I would say don't take left colectomy slightly. If you have an obstructed left colon, it's a loaded left colon, what we normally do is we just empty the thing and do an anastomosis there. Some people want to do a drop lavage and thing, but there's not much evidence that really helps. So I think depending on the mobility of the patients, that will do that. Okay, I think that. Okay, thanks, Miss. I didn't have a long talk anyway. Thank you. Thanks, Nikhil. I think I'm done. I'm still there.
Thank you, Dr. Saklani. Thank you for an excellent demonstration of left hemicolectomy and telling us briefly about left-sided colonic resections. And there's a question from Dr. Deepak Jain. He has asked, when you have a tumor 10 centimeter distal to splenic flexure, we would do a left hemicolectomy or anterior resection. I understand that you have answered this question basically, but you can clarify a bit more.
Sure. I mean, I think for those ones, I think probably taking the left colic artery and the sigmoid and preserving the superior rectal would be better. You would have a 10 centimeter clearance. And if you have excess sigmoid length there, then that should be okay. So I think very important to decide what you're going to do. If you're going to do an anterior resection, you take the IMA at the root, you should make sure you have enough colon or it's quite redundant and it should come down to the promontory. If oncologically, I think what we said with the greater propensity stores, all of them, either segmental resections or anterior resection, they're all okay.
Dr. Saklani, I mean, so one question, like in specifically these kind of tumors, sometimes it will be very difficult to decide on a preoperative scan which procedure we'll end up doing, because it will all depend on the relationship of the tumor to left colic artery, which side more it is, which artery we should take at base, and probably that decision can be taken only intraoperatively. Sometimes
That's
it's
right.
far away.
That's right. First, once you do a laparoscopy, you have to localize the lesion. Or if it's very small, it has to be tattooed. Otherwise, sometimes the small operation can take a really long time. And you may sometimes end up with subtotal colectomy because the left colon may not come down. Yes.
So if I ask another question, is that if colonoscopy was done in some other center and the lesion was not tattooed, and if you don't find it, like what would you do?
In our country, most of the lesions are bulky and you can spot them. But if not, then you can do an intra colonoscopy. You can just put a tape around the previous colon and that should be okay. I think you can do with CO2 insufficient. So it goes away minimum mode and that should be fine.
And so if you have a tumor near splenic flexure, then what would be your approach? You would do a left resection or extended right? Which one would you prefer?
The evidence shows that both of them are equivalent. Extending right hemicolectomy takes a longer time. So we prefer normally a left hemicolectomy with good margin sort of thing. But sometimes you may have to do extended right hemicolectomy. What happens normally if you're doing a laparoscopic surgeon, you would do a left hemicolectomy because it takes a shorter time. On the other hand, people who are doing open surgery, they will say, oh, why do this? Why not do an extended right? It's easy to staple. So I think I did a survey for all the ACP, GPI bumpers, and actually 60% did the extended right hemicolectomy because they were open surgeons, and all the laparoscopic. Well, this is sometime 2010, and all the laparoscopic surgeons had left hemicolectomy. So yeah, but evidence survival outcome is the same for both of them.
Dr. Nikhil,
So
can I
in
ask
term-
one question?
Yeah, please, Dr.
So just, I mean, from the medical oncologist perspective, I mean, consider me as a layman in surgical thing. So just my question is there any difference when you do a laparoscopic versus a robotic, or is it all same in case of colon? I mean, just for my understanding, I would.
I think, yeah, I mean, there have been a lot of studies, the cost, color, and the classic study, they've compared colon and laparoscopic resection. I think initially there were a lot of concerns about port site recurrences. So the initially cost study looked at that sort of thing. But they found no differences, either port site recurrences, peritoneal differences. So oncological first study, first time to local. So I think DFS, OS wise, it's quite okay. And colon is almost standard of care. And now even rectum has become standard of care. So would you do it for T4 disease is the question now, because most of these were not T4 disease for the trials. For T4 disease, some Japanese studies have shown that because of a lot of manipulation there, the incidence of peritoneal metastasis is slightly high. But on the other hand, if selective centers which have come from Cornell, Wales have shown good outcomes for T4. For T4, data is not there. It's a bulky disease. You still have to take a bigger incision. So probably you may want to do an open procedure. But otherwise, for colon, I think MIX is okay. Robotic also, the trial comparing lap and robotic has not shown any outcomes better. But then the robotic people try to do intracorporeal anastomosis. And if you are not done many laparoscopic procedures, then robotic you can do good complete metabolic excision. Even with CME, there is no RCT to show that evidence is better. In our own center, where when we're doing central ligation but not exposing the superior mesenteric vein, I think my colleague Ashwin has looked at data. And the CME, so we didn't find any difference in either DFS and OS. But if you are doing a stapled ileopolic anastomosis and the length of pedicle is long, then local recurrences are given in the MRC classic. It was 14.5%. But if your type of operation is the same, whether you're doing lap or open, there is the difference. But if you're stapling the ileopolic anastomosis or the IMA, and if you're longer length there, then you can have nodal leakage there. But if you do the same procedure, I think most of us are not doing really good quality surgery now. So that I think, and training itself is quite good. So I think it is very less. I think Nikhil would agree with that. Everything.
Absolutely, sir. Absolutely. So there's one more question from Dr. Daya, and he's asking, is clinic flexure growth resection central vascular ligation which vessel? So I don't think we can call it central vascular ligation.
I know. But you will explore the middle colic artery and take the left colic artery at the origin, middle left branch of middle colic at the origin, and then you will take the left colic artery. When there is a T-Rex study which is looking at it, not all of them look at the root. The segmental colectomy is okay. There is a study, international study called T-Rex study, which is looking at the distance from the main vaginal artery supply. So most people would say the segmental is also okay. So you do not always need to take it the root sort of thing.
Thank you very much, Dr. Saklani, for an excellent talk and demonstration. And now I request Dr. Sandeep Nayak to talk about right-sided colonic resections. Dr. Sandeep, please.
Dr. Nikhil, thank you very much. I enjoyed the last two presentations, Dr. Saklani and Dr. Govil, very interesting and quite detailed. So I think they have left less for me to really discuss. So let me just share my slides. Share. So my slides are visible?
Yes.
Okay, thank you. I don't know if there is any way to make the side panel come, but anyway, right. So I'll be talking about right colonic cancer resections, and my focus or the learning objectives today will be to discuss the concepts around this, the anatomy, evidence which is less, as Dr. Saklani was also pointing out, there is very less evidence, or the RCTs are very less. So it's all retrospective analysis and various other studies which are there. So then we look at the surgical steps. So this is the way I have structured this. Now, as far as the concepts are concerned, I think my previous speakers have already spoken the concepts of complete mesocolic excision and central vascular ligation or high arterial ligation and D3. These are the clear concepts which are there. I'll just go into the depth of it because much of it is defined for the right colon than to the left side of it. Now, anatomically, what does mesocolon actually mean? Because mesorectum, we know very clearly, we have been understanding, or we have been using the terminology for a very long time. What does mesocolon mean? Mesocolon actually has not been clearly defined in any particular study. It is, there is still a thought process which is defining it anterior to the Toll's fascia or it is posterior. But what is clear to us is when we do a surgery, the fat in the mesocolon should not be exposed. The fat globule should not be exposed. So there should be a layer of fascia which covers it. So whether you go deep to or posterior to the Toll's fascia or anterior to it is a choice which you have, because there's no clarity about it. Personally, I prefer to go posterior to the Toll's fascia in the retrofacial plane. So that is the personal preference which I have. Now, coming to the central vascular ligation, it basically talks about central arterial ligation, which means for the colon that you're resecting, the arteries should be ligated at the origin. That is the whole idea about central vascular ligation. Now, that is, acceptable when you're talking about D2 dissection. D2, basically, we are talking about the lymph node levels up to D2 level. So what is the concept of D3? When we talk about D3, we are looking at extending the lymph node dissection beyond the standard D2. So I'll define it further, but the whole intention why this was defined by the Japanese is to reduce the length of resection of the colon and restrict the longitudinal size of the specimen and make it more horizontal, in the sense to include more of lymph nodes, representative lymph nodes, and reduce the length of resection along the colon. So that is the intention. Now, they have published a lot on this, but again, evidence, is there evidence to really follow it in a strict sense? We'll come to it later. Now, what anatomically does D3 dissection for right colon mean? This is how you define it. Up to 1 centimeter lateral or to the right of SMV is where the D2 level ends. So from that level to the level or just medial to the SMA is where the lateral extent of the D3 region is, and longitudinally it extends 5 millimeters above the origin of the middle colic artery and down about 5 millimeter, not about, exactly 5 millimeter from the origin of the inferior, ileocolic artery. So that is the extent of the D3. So this is the area we talk about when we need to dissect, or when we say we have completed a D3 dissection for right colon. So this is, and of course, central vascular ligation is a vessel should be ligated, or the artery should be ligated at origin. That's what we are talking about. Now, again, we are talking about variations of loop of Henle. It becomes very, very important during right hemicolectomy because it's a very this is the area where most of the bleedings occur, because the anatomy is highly variable. Look at the type 1 here, which is the most common, and the most common one itself is less than 40%. Occurrence is less than 40%. So we are talking about the variations variations being norm. So they are not an exception. So you have to look at the area very, very carefully. Now, what is the evidence which we have for D3 or type of or extent of lymph node dissection that we need to do for right colon? We have some evidence, some retrospective studies which are there, which, in fact, I would rather refer to this, which is a comparison, which is a systematic review and meta-analysis, which was published in 2021, I think it was published, and is a good article wherein they have found that there is an advantage for doing a D3 dissection, D3 lymph node dissection compared to D2. That is, normal central vascular, mesocolic excision with D2 versus mesocolic excision with the D3 dissection. They found that across overall survival as well as disease-free survival and the local recurrence rates were lower when D3 dissection was performed. Now, I'll point out here, what is also important is, in stage 3, which may be quite common in India when which we come across, in stage 3, there is a 5-year survival advantage of about 27% when it comes to D3 dissection. So that is what you have to remember. So I'm talking, when I say D3, I'm including CME as well as I'm including a central vascular ligation. So extending the lymph node dissection further gives you that much advantage. Now, when do we follow D3? In my practice, what I do is whenever the large tumor we see, that is T3 or T4A, T4B, we do D3. Whenever it's a T2, also our preference is to do D3. And in all cases where we see lymph nodes being positive intraoperatively or pre-operatively, our preference is to go for D3. Now, in fact, when in our practice, I think this is what happens for most of the cases. Now, coming to the surgical technique, of course, we spoke about the advantages of laparoscopic approaches. So, definitely we see people who perform minimally invasive would vouch for a laparoscopic or robotic, or the people who do open would opt for open approaches. But definitely, as far as laparoscopy is concerned, it is known to yield higher quality of surgical specimen, less complications because of and there is enhanced recovery. Of course, we know that we have multiple studies, color trial, multiple studies are there. So better immunocompetence due to less surgical stress and may collectively contribute to better long-term survival is what this particular study says. Now, how do we do this when we do laparoscopically? There are medial to lateral approach. There is lateral to medial approach also, which has been practiced, and cranial to caudal also. We can do the same surgery, perform, it is up to the surgeon's preference. Now, what I do is a mesocolic first approach, which is caudal to cranial. I have found it is more advantageous because I dissect the mesocolon first. I have a good control on the specimen. It doesn't wobble. So those are the advantages which I have. So I will show a short video of right hemicolectomy, wherein I'll be talking about CME, D3, central vascular ligation in a mesocolic approach. Now, how do we perform? This is the position of the patient. Patient is head down position. The cameraman stands here to the left of the surgeon. Nursing staff is to the right of the surgeon. Surgeon stands in between the legs, and the second surgeon or the assistant surgeon stands to the left of the patient. So this is the position. And we use, especially when we have to do the dissection around loop of Henle, I prefer a port on the this port, 5 mm port on the right side. This is 5 port position. In fact, a standard right hemicolectomy can be done with these 3 ports. Patient is in supine position, so these 3-4 ports we can perform a standard right hemi. But when I have to do a central, the loop, that is, dissection around the head of pancreas and loop of Henle, this port also is required. Now, this port, the upper mid 5 mm port, is placed midway between the Xiphi and the umbilicus. This is not at the epigastrium, Xiphi. This is midway. This is a suprapubic port, which is predominantly used for camera for the retrocolic dissection. This is the right iliac fossa port and the left iliac fossa port. This can vary. This can go a little higher up to give you better access. Now, this is the video. I kept the video short because I was told 20 minutes. So I thought I'll stick to that. So this is about 7 minutes video. This is the diagnostic laparoscopy. Now this is the ileocecal junction. You can see the ureter here, and you can I start the dissection. This is the ureter. Start the dissection by lifting the ileum, going into the retroperitoneal plane. So once you go into retrocolic plane, generally so as you go up, you will see the Gerota's fascia here. A Toll's fascia, though anatomically defined, you will never see it as a clear-cut fascia over here. So what is important is to see that the Gerota's fascia is left behind. This is Gerota's, which you can see a clear white layer. This is Gerota's fascia. As you go upwards, you will gently dissect the, dissect it or leave the Gerota's fascia on the kidney. When you're dissecting in this plane, do not expose the ureter, because there should be a layer of fascia left over ureter so that it is safe. So as you go up, you'll approach the transverse colon. This is a transverse colon, and you will see the liver. That's the liver. That's the liver which you are seeing there. Liver and gallbladder will be visualized from retroperitoneum. Once that is done, I go medially. This is the duodenum. And all the fibrofatty tissue over the duodenum and the head of pancreas is lifted up towards the specimen. And this is the superior mesenteric vein which comes into view, loop of Henle and superior mesenteric vein. Now I complete the left side of the dissection. I know visualize the superior mesenteric vein from retroperitoneum itself, because it makes my anterior dissection easier, because I know where the vein is. I have a 180-degree view of the vein to the right side, so I don't have to worry where the vein is. So it makes it very clear. I place a gauze piece behind there around below, and then start the medial to lateral dissection. This is the fold of ileocolic artery, ileocolic fold. So just below that, score the mesocolon. So you can, the moment you score it, you see the gauze which has already been kept over there. So next aim is to reach the origin of the vessels. So as you go medially along the ileocolic vessels, you will see that the vein is usually anterior. So you trace it medially, you will find the supramesenteric vein. Now there can be variation in anatomy because of malrotation, partial malrotations. So those you should be aware when you are looking. You can see it on CT scan also, or during surgery if you notice. So this is the vein. I've come about half a centimeter below the, or 1 centimeter below the origin. This is the ileocolic vein. This is supramesenteric vein, and this is the ileocolic artery. This is the supramesenteric artery. So this is the anatomy. So we are doing a central vascular ligation. Artery can be tackled with ligashore as well. So as you go superiorly, now you can see the duodenum posteriorly and the head of pancreas. Now, the advantage of completing the posterior dissection early enough is that the entire structures are clear to you as you're going superiorly. So, and your dissection of loop of Henle becomes very easy. You have every structure in your vision, and that is and that makes it very simple. So this is the one of the vessels coming and joining. So I will not name them because it's really impossible to say which is which vessel. There are multiple variations. So you have to ligate and be watchful for every vessel that comes there, and there can be connection between these veins as well, which you have to be very cautious about. So this is the right branch of the middle colic artery. And remember, middle colic artery branches out as soon as it originates from the supramesenteric artery. Don't look for that Chauriasia's anatomy diagram where there is a long length and then branching. So that's not the way it works. Now, once this is done, we have to go to supracolic compartment, divide the gastrocolic omentum, get into that plane. Your assistant has to reflect the stomach upwards. Once that is done, all this dissection has been performed posteriorly. Only thing you need to do from superior is identify the rest of the loop of Henle veins and ligate them. Predominantly, the right gastroepiploic vein will come and join here somewhere. So that vein has to be identified. So, and the colonic veins, which can be multiple, which have to be ligated. Now, it is important that we go just above the origin of the middle colic artery. This is somewhere where middle colic originates. We take all these loop of Henle vessels. No need to go and dissect the this area above the veins and arteries. So this is the limit to which we need to go and dissect. So once that is done, the rest of the surgery is simple. You just need to free the colon, right colon, by dividing the peritoneal reflection and define the colonic ileal cut margin, so that we know once we open, we know where to do it. The anastomosis can be done either by hand sewn or by stapled, or whichever is the choice. Sometimes we do intracorporeal depending on the situation and the body habitus of the patient. Is that all? I think, that's all. Thank you very much.
Thank you, Dr. Sandeep Nayak. It was a very informative talk, right from the D3 dissection to anatomy, and then how to go about practically doing a right hemicolectomy. I think everybody would have enjoyed it and they would have learned how to go about it. We don't have many questions in the chat box. I had one question. So as far as lymph node dissection is concerned, so like obviously we know the limit of the D3, which they have described like above the middle colic and below the ICJ. So would you make any distinction between, say, ascending colon tumor vis-a-vis a hepatic flexure tumor when you are doing this dissection in the lymphadenectomy? Will you concentrate more on the middle colic side when you are doing a hepatic flexure tumor, and more on ICJ side when you are doing a ascending colon tumor, or you will just go about them same? Because I will say, dissecting around middle colic is more difficult than along ICJ.
Yes. So see, as of now, I have not reduced the longitudinal length of colon which I am resecting. So all these cases undergo a D3 dissection, whether it's a ascending colon, cecal, or a hepatic flexure. We do the same thing. So as of now, so like the Japanese are talking about reducing the length, I have not started doing it. So it is the same dissection we follow. The entire, I start from the ileocolic artery and go superiorly, finish the lymph node dissection at the origin of the middle colic artery. That is how I do.
Okay.
As of now, because tomorrow, if the evidence becomes more strong to do only D3 and very specific vessel, then I think we should follow that. So see, when it comes to transverse colonic growth, again, it's just the transverse colectomy with the D3. That's what we do. We go to the origin, we do the complete lymph node dissection at the basin, nodal basin. That's what we do. We don't go for right hemi when we are doing laparoscopic. So that is what we restrict to. But for all the right colonic growths, we prefer to do a limited, right hemicolectomy. And another important thing is, predominant in most of our patients, we don't find a right colic artery. It's very rare to find. I think, it will be the same experience for most of us. So right colic is very, very rare to find in our population. I don't know, it's an anatomical variation which is there for us. Though internationally also it is said, but I would say, hardly maybe 20% of the patients I find right colic artery. So again, artery-based resection to do a D3, just because there is, it's an ascending colon, will be very difficult for us.
Now, if I ask you one more question, is that like one hepatic flexure and proximal transverse colon vis-a-vis middle and distal transverse colon. So on the middle or the right side, which one would you call a right colon growth, and which one would you call a transverse colon growth? So where would you start taking the middle colic completely?
Okay, so you see, up to the proper hepatic flexure, we don't take, just purely hepatic at the flexure. But anything just to the, left of hepatic flexure, we start thinking in terms of an extended, because it's a location. So once it's a proper middle of the colon, middle of the transverse colon, definitely it's only transverse colectomy. Now, as you know, transverse colon length can vary. So we can't be really telling you that, okay, 10 centimeter or 5 centimeter. It's an anatomical take which you have to do during surgery. It's a surgical decision on table. That's how I would put it. So if you, I can't put a length to it. So it's a surgical or intraoperative decision to go with a right extended right versus a purely a transverse colectomy in those situations.
Maybe just for a little more clarification for everybody, maybe we can define that in terms of relation to the vessel.
Vessels, yeah.
Yeah. So if it's more on the right side of the origin of middle colic, or if you think that adequate lymph nodes are getting removed, like if you take right colic as base and there is a good distance between the tumor and that base which you have taken, then it's fine. But if you are very close to the base, then I think you should proceed with a extended right and should take middle colic as base, at base.
Yes, I think, yeah, see, the concepts of colectomy, yeah, we have to follow. So it is totally based on the vessels, isn't it? There's no
Yes.
two arguments about that. So it all depends on, that's why that right colic artery discussion also came up. So basically it's an understanding of the vascular anatomy during surgery that will decide how much you are going to dissect. Definitely, no doubts about that.
Absolutely. So I think, do we have more questions? Anybody want to ask anything? Manish, anything? So, Shefali?
Nothing. I mean, to me, it's very good.
Thank you. So thank you, Dr. Sandeep. Thank you very much. It
you.
was an excellent presentation and good demonstration. And with this, I would like to thank Dr. Deepak Govil, Dr. Saklani, and Dr. Sandeep Nayak for making it an informative session, and hope all of us enjoyed as well as learned. And that brings us to the conclusion of this session. So good night, everyone. And next, we will be talking about neoadjuvant and adjuvant treatment in colon cancer. Do join us for this. Thank you. Thank you very much. Good night.
Thank you and good night.
Good night. Thank you.
Yeah, thank you.